Hi, this is Brian Kim. I want to share with you this case of a patient who had an opacified Akreos hydrophilic lens. This patient had retinal surgery and must have had gas exposure, and it caused the lens to opacify. The previous surgeon tried to YAG it and actually even did some YAG because apparently there must have been some capsular phimosis and the entire anterior capsule edge has been shredded. And so it's be difficult to salvage the bag in the situation. So you're going to see my modified technique of the Yamane using the trailing haptic first modification, which makes the surgery really much easier in my opinion. And so I show you my approach to the Amani technique. So I'm making my incisions for the iris hooks. I'm going to put 4 in. At this point when I'm looking at the eye, I do not really know the status of the bag. And so I'm going to really approach this as if I'm going to save the bag and put the lens in the bag. And so I think that's the point, is you want to go in with a certain expectation. However, this patient has a very small pupil. There was no way for me to assess the status of the bag. And so I'm going to put iris hooks in and have a much better idea of what I'm dealing with. But you have to learn to pivot in these situations pretty quickly. And that's why it's really important to have kind of a wide array of surgical techniques in your arsenal to be able to handle these situations. So I go ahead and place the iris hooks in, and it doesn't take that much time. It's a little bit tedious, but I really feel like iris hooks in this situation is really quite advantageous because you can adjust the amount of pulling from each iris hook. Whereas if you had a ring in there, I just feel like it's not as stable. As I'm injecting some intracameral epinephrine, look what happens to the bag. The bag is flopping quite a bit. The IOL is flopping quite a bit as I'm pulsing that BSS. So that's another clue that perhaps this bag is really not that good. And this is when I start to realize the scalloped edges of the anterior capsule or rexus. And so I was thinking, why is it so shredded like that? And then I thought, this is a hydrophilic lens. The patient must have had a capsule contraction syndrome, and the surgeon must have yagged the peripheral capsule in order to extend and open up the rexus opening. And so I'm not really feeling very confident about this bag. I'm injecting some dispersive viscoelastic under the rexus edge with this hypodermic needle, probably a 27 or 25 gauge needle. And I'm going to do my due diligence and go around circumferentially, injecting underneath the rexus edge the best I can and try to open up the bag as best I can. Normally you see a really robust ring of fibrosis around the rexus edge in these cases, but obviously this rexus edge has been lasered. So I inject some more viscoelastic, and then I make my triplanar corneal incision, make a vertical groove, place the blade into the deep part of the groove, tunnel, and then enter. And I'm injecting now some dispersive viscoelastic with the cannula to just open it up some more. This patient didn't have a dislocated lens implant. This patient just had an opacified lens. And so anytime you have an intact bag, you really want to try to salvage it. And so I'm really doing my best to see if I can open up the bag and separate it from the lens. Now I have a microforceps and a Sinskey hook. I'm going to use the Sinskey to get under the rexus edge, lift the lens up, and then I'm going to grasp it with the forceps. But as I do this, you can see the lens tilts, and you can see the bag is just not really very stable. I'm trying to grasp it, and I try to get the Sinskey around the lens so I could save the bag, but I really can't even tell the status of the bag, but I don't really feel good about it. So I go ahead and decide to cut the lens out, and I'm going to Pac-Man it. This is the thing, that those four Mickey Mouse ears are really large within the bag, and when I tried to lift it up, I'm not quite sure what happened, but I just don't feel very confident about this bag. And so with the Pac-Man technique, I'm going to go ahead and grab the other side. You want to grab the other side, the right side part of the lens, and that way you're going to be able to open it up, because you can make sure the left side half of the lens goes down, as you can see here, and then externalize the haptic here, pulling out the optic. Since the left half of the lens is pointing down, it's not going to hit the cornea. So you externalize the first half, secure it with forceps, and I'm going to use the right forceps to protect the cornea as I take out that second half. I make my incision for my AC maintainer now, and then I'm injecting some more dispersive viscoelastic to coat the cornea, marking my cannula tip on the right side, making sure the surface is dry, using my cannula to help me find 180 degrees away. And then this is 2.5 millimeters posterior to the limbus, directly back from that point in radial fashion. I'm going to indent. The reason why I didn't put any irrigation or an infusion is because it's going to make the surface wet, which will undermine my ability to make the marks. This is 2.5 millimeters posterior as well. Make sure it's dry. And then this is one thing I've been doing. In order to steady my hand, I'm placing the cotton tip underneath the pen. And that really gave me excellent control as I was trying to mark. So you'll see here, I use a cotton tip to kind of steady the marker, and I'm able to make a really precise mark. Otherwise, you don't have any leverage point, so you can have a little bit of a shake. Placing my 20 gauge AC maintainer. This is the trocar. I'm going to indent 4 millimeters posterior. About 2.5 millimeters away, I'm going to tunnel tangentially through the sclera, tunneling and then rotating perpendicular and diving in. By doing it that way, you can assure yourself a self-sealing incision. So this is 4x speed. I'm going to go ahead and do the vitrectomy. Actually, this patient really didn't present any vitreous at all. So in these contexts, this patient had a vitrectomy in the past. I'm not really going to perseverate that much because this patient already had a vitrectomy. So this is my right side needle. I'm bending it about 9 millimeters from the tip. And this is the left side needle bending at the hub. Remember, the bevel of the needle is going to face the approach of the haptic. That's very important. Make my contralateral limbal incision, and then with my left hand holding microforceps, the right hand holding the injector, place it into the eye. My surgical assistant is going to start dialing the leading haptic out. I tell her to stop. I grasp the tip. I tell her to continue. She continues. I externalize the leading haptic. I tell her to stop, and then I take over and I start to dial the optic into the anterior chamber, and I'll make sure the optic comes out correctly. It did a little bit of a funny maneuver there, and so I'm going to stop here, make sure the trailing haptic comes out, pointed to the right, and then I'm using the Maltzman, I'm sweeping the leading haptic to the left. Injecting some more dispersive viscoelastic to protect the cornea, placing the trailing haptic in a U-shaped configuration within the incision, holding the trocar with my left hand, tunneling through the sclera with the needle, 2 millimeters, and then diving down. I can actually see the needle as it's coming through, and then I'm diving in. So that's the important thing, holding the eye with the trocar, So this is important. I'm going to hold the haptic at the apex of the U, docking the haptic on the bevel of the needle, straightening it out, and then it slides right in very nicely. So again, I hold the haptic at the apex of the U. You make sure the bevel is facing the approach of the haptic. You dock the haptic on the bevel of the needle, straighten it out, and then it goes right in. Disengage the needle from the syringe, internalize the leading haptic, hold the incision with my right hand, placing the needle. You want to make sure you catch the sclera. You saw that I didn't. Once I did, I start to tunnel, 2 millimeters, dive down. And that's the key. When you have more experience, you have a sense of how far the needle is going. And so I'm pretty sure I went 2 millimeters, grasping the haptic. Again, the bevel is facing the approach of the haptic. You dock the haptic on the bevel of the needle, flatten it out, straighten it out, and then it goes right in. So I'm going to go ahead and pull the needle out, and the haptic should come with it. Grasp it with forceps, making sure that not too much of the haptic comes out, because it's going to put stress on the other side if you let it do that. And then you cauterize the tip. And do the same thing on the other side, pulling the needle out. And as you pull the needle out, the haptic should come out as well. I try to make sure not too much of the haptic comes out again, because it stresses the haptic on the other side. And then you cauterize. And this is another important point. When you're internalizing the haptic, if it goes in too easy, that means your scleral tunnel is too shallow. It takes me a lot of effort to push that haptic flush to the sclera. And so when you do it that way and you have some resistance, you know that you have a very good tunnel. If you don't, that means you were too shallow. So what does it mean if it's too shallow? If it's too shallow, that means you don't have a broad base of scleral shelf for the haptic to sit in. In other words, if it's too shallow, the haptic might be prone towards tilting downward towards the vitreous space. And if the haptic tilts downward, the IOL will be decentered or tilted. So I'll reapproximate the conjunctiva and take the hooks out. I go back in and do my vitrector-assisted PI. Because I didn't actually orient my chair supero-temporally, I actually am right in the temporal position. This is a little bit of an awkward maneuver, but I go ahead and do the vitrector-assisted PI. You can see the vacuum is low, the cut rate is very low, and then I switch to IA cut mode, and this is to remove the viscoelastic from the anterior chamber. This is a little bit of a tedious process because of the viscoelastic. This dispersive viscoelastic doesn't really come out that fast with this vitrector versus the INA tip. So I'm going to use a BSS cannula to pulse to create a little bit of turbulence to kind of loosen up the viscoelastic as I'm doing the IA cut, removing the viscoelastic here. And so this is intracameral triamcinolone. Go ahead and remove the triamcinolone from the posterior side. And then in the front. Again, I'm really going through the motions. Again, this patient did have vitrectomy, but just out of habit and just to be thorough, I'm going through the motions, making sure I don't take anything for granted here. And there's clearly no vitreous. I didn't encounter any vitreous during the entire case. So I'm just going to fast forward the closure. I always put in a tenon suture when I'm dealing with vitrectomy. You just don't want to have any potential strands to the wound. So I make a tight suture and then bury the knot, taking the trocar out, massaging the sclera. Take the AC maintainer out, and then I hydrate my incisions. So again, this patient had an opacified hydrophilic Akreos. The patient also, once I opened up the pupil because it was really small, I noticed that the entire anterior capsule rim was completely shredded. I presume this is because the patient had capsule phimosis and the surgeon went in and zapped away the anterior capsule phimotic material. As I tried to open up the bag, it was really impossible to salvage the bag, especially with such a large diameter lens with those Mickey Mouse haptics. So I explanted that lens in a Pac-man technique. That lens is malleable, so it was easy to take out. And then you saw the Kim modification of the Amani using the trailing haptic first technique, externalizing the leading haptic, going after the trailing haptic first, which is quite easy this way, making sure the bevel faces the approach of the haptic. You want to dock the haptic on the bevel of the needle, flatten it out, straighten it out, and then it glides right into the needle. So I hope this was helpful to you, and I thank you for your attention.